And I'm serving as your chairman today of this committee. I appreciate all of you being here. We have a presentation which we'll get to in just a minute, but I want to acknowledge our Sergeant at Arms, Terry McGraw, Nina Lodge, Bill Riley, and Russell Salisbury. And we do have some pages along the back. We'll let y'all either stand or wave, whatever you're comfortable doing. Drayton Conley, Representative Gillespie, Clara Parlier, is that right? I'm close. Representative Ryan, Joe Satterwhite, Joe, Charlie Miller, Potter Williams, Representative Hastings, and Jake Zune, Representative Lou. Thank y'all for being here, and hopefully you'll enjoy this presentation, and we'll get a little bit out of this, can take it back, talk to some of your colleagues about maybe coming for a future page program. With that, we do have I think you're going to find this a very interesting presentation. The state provided some pilot money for this program, and I heard it a few months ago when I was at an event, and I felt like the full committee should hear this because it may be something that we expand across the state as time goes by. So with that, I'm going to call on the Carolina Complete Health folks, who's going to be, well, come over here, I guess. Oh, you just want to stay there? That's fine. Good. And I'll let you introduce yourself, and then y'all can start with the primary spokesperson and go right down the line. And I think everybody should have a handout. It's NC State Red, in case you're wondering. Okay, we'll turn it over to you.
Thank you, Chair Lambeth and representatives on the committee. I'm Chris Patterson. I'm the CEO of Carolina Complete Health. I'll make a few opening remarks and then turn it over to the team. We are very proud to be your provider-led entity among the Medicaid PHPs. And we're also here to let you know that we have now merged with WellCare of North Carolina. The name remains Carolina Complete Health, but we are now the largest Medicaid health plan, and proud to serve the members of North Carolina and DHHS and the legislature. Today, you will hear about one of the many innovations that health plans have been able to put forth in this program. This particular one is, to avoid any confusion, it is not part of the Child and Family Specialty Plan and the many great things that are happening there. It is separate from that, but it is an innovation that's been supported by the Department of Health and Human Services, and we're excited to tell you more about it. So with that, I will turn it over to our Chief Medical Director, Dr. Michael Utek.
Good morning, and thank you all for having us. We're really excited to present our pilot. My name is Dr. Michael Utek. I'm an emergency medicine physician practicing in Wake County for, well, way too long, over 30 years. And but very excited to be here and tell you a little bit about a project that we did that we thought had some really good outcomes.
Hi, I'm Katie McKay. I'm a licensed clinical social worker and the Senior Director of Clinical Operations at Carolina Complete Health. And we're very thankful that you allowed us to come today and hope you enjoy what we have to share. And Dr. Utek's gonna kick us off.
So, you know, one thing that we all know, probably in this room or may not know, is the problem with boarding of behavioral health kids in the emergency department. You know, it's not, this is not unique to North Carolina. It's a national problem, but North Carolina has a really big problem, and it's been going on for a long time. These are, and I kind of want to draw your attention to these slides up here and give you a couple of seconds to look them over, because this is the real world stuff that we heard. You know, as an emergency physician practicing as long as I have, I've had a lot of opportunity to talk with my colleagues across the state, and this is the kinds of things we would hear. This is not unique to any one area. The idea of kids spending weeks or months in an emergency department because they can't be admitted and they have nowhere else to go. They don't have windows. They don't have an opportunity for activity. They have sitters sitting outside of their room. They're not getting education. And this is going on for weeks and months, if not longer. So we set out to, in working with my emergency medicine colleagues and behavioral health colleagues, to hopefully try and come up with maybe a solution that will help. Not a one-size-fits-all, but a solution that we thought made sense. In about 2023, one of the great things about being in a provider-led entity is that we have the ability to be innovative. I think innovation beyond other health plans. And we have several work groups: emergency medicine, behavioral health, pediatrics, primary care, and women's health. And what we sort of noted was that there was a common theme, and everyone was noticing this crisis of children boarding in the emergency department. And so we sort of, in collaborating with them, and then also meeting with the state, because we made sure that we wanted to align with North Carolina DHHS in regards to kind of the work they were doing, because we know that DHHS is also very interested in this topic. And so we set out to devise a pilot that we were hoping would help address the problem. And I want you to understand, this is not a problem with a failure of the emergency department. This is a system failure. And so you can't, this is something that needs to be addressed. The pilot was designed to address the gap that was occurring amongst community behavioral health and amongst emergency departments and the children in the emergency department. So we really set out to ask a very simple question. We wanted to keep this simple, and that was, what if we had someone really dedicated to the emergency department, a singular person to dedicate themselves to be involved with these kids, to be able to provide therapy, and then also, what if we could make sure that when these kids left, the families had a resource, that they weren't just being cast out back to their community in the same place they were, but they had someone that they could align with to help them through their crisis. Go on, Kim.
Thank you, Dr. Yu. So as Dr. Yu mentioned, that was our primary question. It's a simple question, and as we were working with the department and talking to various stakeholders, work groups, we identified a three-prong approach that we thought would really help with address the gap that Dr. Utek mentioned. As you see here, we called the pilot Crisis Intervention, Therapy, and Education based on this three-prong approach. And I do want to mention an important note here is this pilot was payer blind, meaning we didn't just have the interventions for children and adolescents that had Medicaid through Carolina Complete Health, but all comers. So anyone that met the pilot criteria, the interventions were for those individuals. So private insurance, no insurance, Medicaid. So I just want to point that out. So the three-prong approach, as you can see here, is one, a dedicated behavioral health clinician in the emergency department that was dedicated to these children and adolescents at risk of boarding. So these are kiddos that don't meet inpatient admission, but maybe they're at risk of being left at the emergency department by a guardian, a parent, because there are concerns with taking them back home. It could be that there's other children in the home and they are worried about aggression, and that can be scary and they don't know where to always turn. So the clinician within the hospital was dedicated to those individuals. And emergency departments, they have teams that work on care coordination, discharge planning, those kinds of things, but this was really dedicated to do that stakeholder engagement, collaboration, and really identify resources, which I'll get to in just a second, resources that the parents could have to take these kiddos back home with them. And one thing we know is that we need that really point of contact, warm handoff for more efficient transition for the children and adolescents. The second piece was a community-based crisis response, referred to as MORS. This is Mobile Outreach Response Engagement and Stabilization, and they are a community-based provider that can respond within 45 minutes to an hour of a crisis, and then they can provide service up to 8 weeks. So that's definitely different than what you would normally hear with mobile crisis because of that ongoing stabilization and care coordination for linkage to other services. So the emergency department clinician made those referrals to the MORS team to help with that collaboration and allowing the parents to have that resource. Also, the MORS team could respond directly from the community with stakeholders, parents, guardian, calling in directly to MORS. So as we were doing the pilot, the hope would be as more people learn about MORS, increased calls from the community before individuals even get to the hospital. That's ideal. The other piece, the last piece of the three-prong approach was education. So something that we heard ongoing in our work groups and conversations with the state is just there's a lack of awareness of other services, crisis services that are available to individuals. The emergency department's kind of the go-to, that's what people know. So getting education out there about other crisis services, mobile crisis, MORS, facility-based crisis, behavioral health urgent care is really important for us to provide that education and awareness for the community. I'm gonna pass it back to Dr. Utek and he's gonna go over the outcomes that we saw with the pilot.
Yeah, so I just want to reiterate that this was a pay or blind. This was fully funded by Carolina Complete Health. We paid for the emergency department LCSW for 1 year. The pilot ran from January 1 to end of December 2025. And we also paid for 8 weeks of MORS coverage. So prior to us starting the pilot, we chose this emergency department, Novant Presbyterian Hospital in Charlotte. It's a resource-dense community, and they had a MORS program already set up. But their pediatric emergency department was very representative of the kinds of standard pediatric emergency departments, 15-bed emergency department, and they were holding kids of that 15 beds every day with behavioral health issues, about 9 rooms. So you have a 15-bed emergency department, 9 rooms are being held every single day. And I think their bed hold times were greater than 1 year for every year, which was remarkable. But it was representative of not only what we saw in Mecklenburg, we'd see this in Forsyth, in New Hanover, in Wake County. So all the different counties, everyone was having the same problem. So we, year over year, there was no change in volume of kids showing up at the emergency department. We had about 1,000 behavioral health kids. And of those, about 115 of those kids met what we call our pilot criteria. And these are unpreventable social holds. These are kids who cannot be admitted. They're not gonna be admitted. They have no medical reason to be in the hospital, but families, group homes, whatever other caregivers just left them. And they were stuck. Nowhere to go, and you can't get them a safe discharge. And so, like as I said, pre-pilot, they were averaging about 50 to 70% of their rooms were held by what we call unpreventable social holds. After we implemented our pilot, they were seeing about 4 to 6 weeks of hold per child, per child. And some, believe it or not, up to 9 months. 9 months. They had I heard one kid who was in one of their departments, 13-year-old. He was there for 7 months. He gained 100 pounds. These are horrific stories, but this is what happens because there's not much else to offer. After this simple pilot, simply putting in a behavioral health clinician and then giving them this warm handoff to a MORS crisis who could be there for the families. That 4 to 6 weeks dropped to 2.1 days. Let that settle in for a minute. This happened very, very quickly. It didn't take a lot. When we talk about emergency departments, we talk also not only about the length of stay, but we talk about a left without being seen rate. Those are the folks that come to the emergency department, come in to be seen, and they're never seen. They just leave. We're not waiting any longer. And in the average emergency department, probably it's in the 3 to 4, maybe over 2% range. They actually did pretty good considering they were really running half an emergency department. Within the first quarter, that we had almost a 45% decrease in the left without being seen rate to about 1.2%. At the end, it was actually, that number is 1.01%. It's actually 0.89%. And as a follow-up, after 6 months now that it's continued moving forward, we'll get to that in a little bit, they're still seeing around a 0.89% left without being seen rate. If you think about those 115 kids, had those kids not been intervened with, that's an average of 4-week stay and nearly a year of stay within the emergency department, occupying those 9 beds available for an entire year.
So we've been talking about this pilot for a few years now during our prep, and then of course a year of the actual pilot. So we could go on and on. But I do want to share next steps. As Dr. Utek mentioned, the left without being seen rate continues to go down at that emergency department because the Novant did maintain that licensed clinician based on the effectiveness of this pilot, and just really want to thank our partners because this pilot wouldn't be possible without them. So Novant, like Dr. Utek mentioned, and Spark Services and Programs was the Moore's provider. And both of those things are continuing. So the pilot was very effective, as you see from the outcome. So next steps are our funding ended in December 2025 for the pilot. So that's continuing. And then the next thing is we're actively planning for phase 2. As Dr. Utek mentioned, with phase 1, we did pick a resource-dense region. We wanted to see if we could prove the outcomes for that first question that Dr. Utek mentioned at the beginning. We know that it works in a resource-dense region. Moore's was already up and running. Mecklenburg County has the luxury of a lot of community-based resources. In our next phase, we do want to partner with an emergency department that's in a less resource-dense area because we think it's important, and we recognize that this is one tool in the toolkit, that this might not work in the exact same way. We have to be flexible on what we have outlined as the best practice for this. And so that's why we want to move into a region where there's a little bit different of what would be available for community-based service providers. And Dr. you want to add anything?
I just wanted to say one last thing. Obviously this is a very high level operational view in a very limited time. So there's a lot more details and there's a lot more story to tell that we're just not able to do because of time constraints here. But I did want to point out, and I think Katie, that last slide. This was a comment from one of the emergency department physicians in the pediatrics emergency department. The one thing we like to say, the law of unintentional good consequences. And not only did it improve process and throughput and patient satisfaction, but it also improved staff satisfaction. This was when we spoke with their emergency department nurse manager, Courtney Cortez, that they were having a real hard time keeping their ED staff with nurses because they were miserable, right? Because they're not there doing pediatric emergency medicine. They're just doing behavioral health babysitting. It was sort of a mess. And really within the first few months, she said, we don't have any more locums working here. We don't have any more contract nurses. We have a staff that is really dedicated because they know now that there is a resource for them, and these kids aren't sitting around getting nothing, but we are able to move these kids quickly and efficiently through the emergency department. So I just wanted to point that out. And if anyone ever has any questions or wants a lot more detail, let us know. Because like I said, very high level overview, but a lot more to the story. And I thank you all for your time.
Well, thank y'all for being here and sharing that outcome from the pilot. It's very impressive. And, quite frankly, we've heard problems with our ERs and boarding for a while. And it's an issue that we've certainly got to continue to focus and fix. And behavioral health patients are one of the reasons why there's so many patients hung up in the ERs across our state. Chairman White, you have a question?
Thank you. Thank you, Mr. Chair. I do have a couple of questions. First of all, I just want to thank you all for being here today. This is music to my ears. My hospital has been overwhelmed with this, as I'm sure many of the chairs have had that same issue. I do have a question. Is there an age, with your program now in the pilot stage, is there an age range that the youngest and the oldest that you can take? In my district, there has been a 26-year-old that came to live at our hospital for a year. So that's why I'm asking this question.
So for the pilot, we went through age 20. So for adults, we have not done a pilot around that yet, but that is something that we hear as well, that discharge for those individuals is difficult as well.
Follow up.
Follow up, go ahead.
And one other question. Who are the people that can refer people to this program? And the reason I ask that is because our Department of Social Services has been a primary provider of these type of clients to the hospital and then leave them there. So, and they were not diagnosed necessarily with mental health issues. They were just foster children that people drop the ball and that they put them in the hospital and they stay there. So if you all have had that experience, I'm sure you've had, if you could speak to that. Thank you.
Ms. McKay?
Yeah, sure. So for the MORS program, it depends on what area you're in. The state does have some pilot MORS programs as well. So it depends on what county. But yes, Department of Social Services can make referrals directly into MORS. With our pilot, that was one thing that we wanted to see was an increase in referrals directly from the community. So it could be parents, guardians, Department of Social Services, schools, so anywhere where that crisis was occurring.
Chairman Reeder.
Thanks very much for a great presentation. You mentioned that the health plan funded this. What was the cost of the program? And if you would just maybe for a minute or two talk about what all is included in the MORS program.
So we funded the behavioral health clinician and then MORS for up to 8 weeks. For the behavioral health clinician in Novant, we paid $90,000 for that actual clinician. And then for MORS, for up to 8 weeks of service, it was right around $131,000 for all of the members. I believe for MORS, that was 42 members that initiated the service. And I will say too, just to point this out, we selected a MORS team that was already up and running. Of course, if you were building out a new team, the infrastructure to build a team would be much more costly. So the $131,000 would be what the actual cost per member was for the service duration.
Representative Cunningham.
Thank you, Mr. Chair. Ooh, y'all done some work, and I'm very pleased to see this. Of the beds that were in Novant, the 15 beds, were those just plain pediatric behavior health beds, no three-way beds?
These are just treatment room beds in the emergency department, no differentiation. So any child that presented with any complaint can be in any of those beds.
Follow up, Mr. Chair.
Follow up.
The other question I had is the interaction between the LMEs, since a lot of those children fall up under their care and a lot of them end up in the ED, and then we see that sometimes they have a difficulty in finding the actual necessity of placement for the curative care. Do they interact with you all?
So because this was payer blind, we specifically could not have like all the in the weeds details of every member given HIPAA. So we did have some data points that we could capture, of course. And the clinician did have a few of those scenarios, but I will say she was very, very good. This is an awesome clinician that was able to create rapport very quickly and have those difficult conversations about getting the kids where they needed to go. We did have a couple outliers in the pilot where there was, I think, 2 or 3 situations that you're speaking about. From our perspective, we did not do the collaboration with the tailored plans. The clinician at the hospital did, along with the Moores team.
Okay, thank you, Mr. Chair.
Representative Blackwell?
Thank you, Mr. Chair. I've got a couple of questions maybe. Thinking about the potential for expanding this program, something I simply don't know. Is there a behavioral health licensed clinician license, or is that a descriptive term that is inclusive of several different licenses? And if so, who are these behavioral health licensed clinicians?
Yeah.
And to expand on it a little bit, what can you tell us, if you know, about the pipeline, the availability of those people statewide?
Sure. So that's a great question. So behavioral health clinician encompasses a few different clinical individuals. So it would be a licensed clinical social worker, a licensed marriage and family therapy, a licensed clinical mental health counselor. That's typically what you would see. I can't answer the specific question around what that looks like across the state. I would have to do a bit of research to gather that, but that's really behavioral health clinician encompasses those 3 licenses.
Just comment and final question. I think as you move into potentially a less resource-rich environment, the availability of these clinicians is something that we seem to be struggling with. But you say that this does not include young people who do not meet, people who present to the ED but do not meet inpatient admission criteria. We have a problem that we can't place the ones who meet inpatient admission criteria. You all simply, as soon as you determine they need an inpatient bed, you don't deal with them, so you don't know what happens to those folks in the ED.
Go ahead.
Do you want, okay. Yes. So the reason we didn't have the individuals that met inpatient admission as part of the pilot is because our goal was to get them back out in the community. So that warm handoff to Moores really was to get them right back out into the community, because we know that ED is not a place for these individuals to be. Because if they meet inpatient admission, can't really move there from the community aspect, so we didn't address that piece of things. But I do know that that's also an issue with getting kids to beds.
And if I just might add one little, like I said, there's a lot more information here than we can give, but I'm going to give you just 1 minute. But what we did sort of learn anecdotally was, in this particular hospital, they had a behavioral access team that would see these kids, but they were also responsible for their inpatient kids. So it would take them sometimes up to 24 hours just to see the kids to do the initial assessment. In having someone dedicated to the emergency department and having a warm handoff to the Moores program, they knew that these kids were being seen immediately. And so what was happening was it gave the behavioral health team more opportunity to work with their inpatient side. So they were decreasing the length of stay for their inpatient kids, because now the pipeline was being able to be more free-flowing. And so that also allowed not only the kids that met our criteria for our pilot, but those kids that did need to be admitted. So the entire process improved. We didn't measure that. We didn't set out to measure that directly, but we do know that anecdotally it improved the entire system flow.
Representative Campbell?
Thank you, Mr. Chairman. Not exactly a question as much as a compliment to what you guys are doing, what you're accomplishing. I feel like I should have brought gifts for you. But I will say another perspective of potential downstream benefit to what you guys are doing. At our emergency room, we looked at both the adult patient and the pediatric patient population at our emergency department. and we looked at factors that affected time from presentation to assessment or disposition. And the number one correlating factor, and there wasn't a close second, was at the time of the patients presenting, how many behavioral health hold beds were being occupied in the emergency room. I started practice in the early 2000s when I would have a consultation in the emergency department maybe twice a year. I would see a behavioral health hold in the emergency department. It's not uncommon for a third of our bed capacity in the emergency room to be filled up with those currently. Starting with COVID, but it has continued. Before then, I'd never done a consult on a patient in a hallway, and now this is completely common. So I just want to compliment you guys. This is a tremendous need, and I will emphasize to the committee that every bed that is being tied up for this situation is not only getting the resources and treatment for the kid that's in that room currently, but that's a room that's not available for an acute medical condition that presents to the emergency department. So thank you for what you're doing. Would you be willing to go statewide in 15 minutes?
Well stated, Dr. Campbell.
Give us 20. We can do it in 20.
We have two more signed up to speak, or will speak, and we're going to have to, we're over time. We have a tight schedule today, but I would encourage, if there are still questions, to send those to me or one of the other chairmen, and we'll get those answers. And then maybe, if you're going to hang around a little while, maybe there's a couple of you may want to spend a little bit more time. I know Representative Cunningham would probably like to do that. We'll go to Representative Pirtle.
Thank you, Mr. Chairman. I want to thank you for the presentation. One of the best presentations I've been privileged to be a part of since I've been down here, to be honest with you. I'm a huge advocate of mental health issues. Prior law enforcement, we had to look what we could do within our span of control to address the issues facing us. I compliment you on what you've done. I think this is a great model for more than just children and adolescents. The Moores program in and of itself is got so much potential. Soft handoff is the key to success. You give us a lot of statistics. I'm one of those guys that like numbers, and I looked at it internally from a law enforcement perspective on how this was impacting us. But I am interested in, what you didn't talk about, is the adolescent consumer. How did you positively impact those consumers so that maybe they were stable? They were stable for much longer periods of time. And so if you could comment on that. But again, thank you for what you're doing. I so much appreciate everything that you got to do. And I'm excited about what you're going to do in those less density provider areas. Like you mentioned for Forsyth County. There's some more even denser than that. But thank you.
Okay.
Thank you for your question, and I will say, from being for law enforcement, one thing that the data did show is law enforcement. That was where the majority of the kids were being brought into the ED. So just wanted to throw that out. But for the individuals that were pilot identified members, the 115 in the ED, we didn't have many readmissions. So I think we had total 7 readmissions out of the 115. So the Moores program was able to maintain that stabilization. And I will say too, not every single 115 member initiated with Moores for various reasons. But only 7 readmits. So I think that does tell a positive story about what that meant for the child.
Representative Servania, and that will be our last question.
Thank you, Chair. Some comments and questions to the group. First of all, to say thank you so much for this work. I've worked in this space, and it's true, it's a national crisis. I worked in Texas and now here. And when I was working in Wake County, it would keep me up at night. And I walked in with some of my former support at Alliance, and we would talk about it every month, every week. What do we do with our children? So, and trying to find solutions. So thank you so much in this. I will say, and Ms. like you answered a little bit because I wanted to ask, because this is a very limited time space, and I wanted to see what readmissions were. But I do urge that, you know, I'm an epidemiologist, so longitudinal, like I want to see more in terms of time to see what the adolescents and children outcomes are, and to see in long-term admissions for your next steps. And I also, Doctor, you're here in Wake County. Let's try to pilot it not only here, and also it's identified in many of our counties that we still have children and adolescents in those EDs. Let's get that to 0. Whatever we can do together to do that. But keep following the data. And then, yes, it's a systemic problem. We have a responsibility to try to find the next placement if it needs to be inpatient. But at the end of the day, we want children and families to connect back to their families. We want children and adolescents to grow and thrive in a positive way. So thank you again so much.
Thank the committee, and thank you for being here. My goal was to get the committee excited, and I think you've done that. And we'll see where this might go. Money is precious. In fact, I wrote down the quote by Chairman Blackwell about less resources, and so we're struggling with that, but I think your pilot has a good outcome that we can certainly build on. So we look forward to working with you and trying to expand this across state. If the committee will watch your calendars, you know, next week will be out, but we are looking at future bills in hopes that we can get more bills through the committee in the next couple weeks. So stay tuned. Committee's adjourned.